My name is Dr. Rachel Cady. I'm an obstetrician gynecologist and a menopause practitioner. I work at Cuyuna Regional Medical Center, and I've been practicing here for about 16 years. So I think it's important, first of all, to recognize that most perimenopausal and postmenopausal women will notice some degree of change in their sex life at that period of time, right? And so a lot of times women just want to talk about what's normal, what is causing whatever particular concerns they're having, and to not be embarrassed by that, and also to understand that the average woman's living into her mid-80s now, and so a lot of women would like to maintain the option to be sexually active, and so they want to just not be put out to pasture, if you will, to be kind of shut down because they're too old, whatever that means. And so commonly when somebody has concerns about maintaining a sex life after menopause, a lot of times their concerns are more that they might be having new issues with discomfort with vaginal intercourse. And so they'll describe what we collectively refer to as genital urinary syndrome of menopause, or GSM, and that affects about 80% of postmenopausal women. And what that's caused from is our ovaries make estrogen, and so when with menopause our ovaries don't make nearly as much estrogen. Our estrogen levels go down markedly, or in that case, if ovaries have been removed, our estrogen levels go down markedly. And estrogen works not only as a natural lubricant for the vulva, meaning the area from our pubic bone to a tailbone, but also the vaginal area, or area around our urethra. And so the skin itself gets drier, but also equally importantly, the blood supply decreases, the muscular kind of stretch to the tissue also decreases. So any sort of friction from intercourse or any other contact oftentimes will result in some like paper cut type sensation, rubbing, tearing, more irritation, burning, those kind of things. And so commonly women in this age group will have concerns about that is obviously impacting their sex life. Therefore, they don't want to do anything that hurts. Therefore, why would they want to have sex? But they kind of do want to. It really just depends on the patient. So it's incredibly important to just get that history. There's other causes too for some women to come in with issues revolving sex after menopause. Sometimes it's more of an issue with vulvar skin, so the skin on the outside. Again, we talk about lichen sclerosis. Sometimes the skin is tearing or there's some scarring. Another common issue too is pelvic organ prolapse that affects about 30% of women, and where the support tissue is damaged within the pelvis, and there might be the bladder kind of coming down into the vagina, the top of the vagina, the back wall of the vagina. And also importantly to mention, incontinence of bladder or bowel is common as well as we age, and so certainly that's, we know, has a big negative impact on sex after menopause. And then I also want to just mention low libido, something called hypoactive sexual desire disorder, meaning low libido without any obvious cause, like a relationship problem or alcoholism or anything like that, where they just don't have the same desire that they used to have, and it's something that bothers them, causes some distress. And so that's a whole other very important area of issues related to sex after menopause. And so there's actually a really well-defined process of care for those patients. There's different causes, but we take a full history. What medications are they on? What's their lifestyle circumstances, relationship circumstances? Do they need sex therapy? Those kind of things. All other issues with standing, though, oftentimes it is more of an issue related to somebody's testosterone level. This is for postmenopausal women. We know that testosterone levels do have a role in somebody's libido. And so testosterone levels do start to decline with age. It actually starts to decline in our 30s. But so a lot of postmenopausal women, if they have a low testosterone level, and would do well to be supplemented with a little bit of testosterone cream. Just depends. But these are some of the things that we talk about. And first and foremost as well, to establish, after you've taken your history and those kind of things, what's the patient's goals, you know, and also understanding that there's other aspects of sex after menopause that might be bothering them too, particularly, you know, issues with orgasm, arousal. We think about different neurologic problems, those kind of things. We know that the majority of postmenopausal women will notice some sort of changes to their sex life, of which a lot of those changes are not great changes and things that are distressing to them, and they feel like they're the only ones having concerns, and that is absolutely not true. So, and this is actually a time, perimenopause and early menopause is a time where low libido concerns peak. And so to know that they are, you know, in a part of a big group of women, and in fact, the most, the fastest growing segment of the population of women, and that oftentimes there is an underlying issue where it's more of a hardware problem, not something wrong with the person herself. And so that to me is the biggest thing, is that it's a quality of life issue. Women don't want to be put out to pasture just because they're in their 50s or 60s or even 70s, 80s. I don't care. There's not a right time to, you know, to just say I'm done having sex just because there's no hope for me. Again, it really depends on what the patient's priorities are, what's important to them, and if it's important to them, it's important to me. And a lot of times there's something going on and something that we can at least offer the patient. The patient can just call directly to our OBGYN clinic, and in some cases we'll send them questionnaires ahead of time for them ideally to bring in at the time of the appointment, but we reach out to them and get them set up for the appointment. They do not need a referral.